Welcome back. I'm Harshal, your lead instructor. And before we dive into today's explainer, I want to say, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Okay, let's get into it. Today, we're taking a deep dive into the absolute core of hospital operations and revenue. We are going to demystify the Inpatient Prospective Payment System, or IPPS for short. Look, whether you're a coder, a physician, or an administrator, understanding this system, it's not just optional anymore. It is literally the definitive language of healthcare reimbursement. Here's our roadmap for the day. We're going to start macro with the MSDRG architecture, then zoom into severity levels, the present on admission rule, and how to decode the ICD-10 PCS. Finally, we'll wrap up by looking at root operations and some high-impact real-world scenarios. But before we get totally lost in the weeds, we have to ask one foundational question. What exactly drives hospital reimbursement? I mean, we're tackling the very real financial reality that precise clinical documentation is the absolute lifeblood of healthcare revenue, and compliance too. Because in the inpatient setting, you aren't just paid for every individual bandage you use or every hour of nursing time. You are paid based on the clinical story you tell. And if that story is vague, well, the hospital simply loses resources it rightfully earned. It's as simple as that. So take a look at this. This outlines the MSDRG architecture, and it shows exactly how inpatient cases are partitioned into medical versus surgical groups. This happens based on major operating room procedures. Think of the MSDRG grouper as a massive logic engine. It takes all your ICD-10-CM diagnoses and your ICD-10 PCS procedures and funnels them, first, into one of 25 major diagnostic categories. From there, if there's a significant OR procedure present, the path splits into either a medical or a surgical DRG. It's kind of like a giant sorting hat for hospital billing. Let's break down this MSDRG architecture a bit more to really see how it works. At a macro level, the Centers for Medicare and Medicaid Services, CMS, groups thousands of possible diagnosis and procedure combinations into roughly 750 distinct payment categories. The modern version we use in the US is the MSDRG, or Medicare Severity Diagnosis Related Group. But here's the thing you have to remember. An MSDRG isn't just about clinical care. It is fundamentally about measuring and compensating for resource consumption during a patient's stay. Every single DRG represents a group of patients with similar clinical characteristics. So the formula is basically clinical similarity plus resource similarity equals one payment group. Now, let's move on and look at how this all builds into severity multipliers, because honestly, this is where the magic happens. These severity multipliers are the true moneymakers in the IPPS. Once we know the base DRG, we have to determine, well, how sick was the patient really? Almost every base DRG is split into 3 tiers based on secondary diagnoses. As you can see, if you have no complications documented, you get the lowest base payment. But capturing just one complication or comorbidity, what we call a CC, pushes you up to the middle tier. And even more critically, capturing a major complication, an MCC, like acute respiratory failure or sepsis, that immediately elevates the tier to with MCC, which yields the absolute highest reimbursement relative weight. But capturing that severity comes with some really high stakes, which brings us to a crucial rule: present on admission. CMS is crystal clear on this. They will absolutely not pay extra for conditions that a patient acquired while in the hospital. So let's say a severe condition like sepsis or a DVT develops 2 days after admission. The present on admission or POA indicator is assigned an N for no. It was not present on admission. When this happens, it cannot be counted as an MCC to bump up your DRG tier. Actually, it's worse than that. If it's considered a hospital-acquired condition, it results in a bundled payment penalty and triggers an intense quality review. Okay, let's shift gears and transition from diagnoses to the micro-level precision of procedure coding using ICD-10 PCS. While diagnoses tell us why the patient is there, procedures tell us exactly what we did to help them. And every single ICD-10 PCS code is this fully combinatorial 7-character alphanumeric structure. It demands absolute clinical specificity. There is literally zero room for vague documentation here. You can't just write surgery and call it a day. You have to clearly define the section, the body system, the root operation, the exact body part, the approach, any device used, and a specific qualifier. The whole shebang. To put that into perspective, take a look at this procedure code, 02103Z. It systematically builds out the entire story of a coronary artery bypass graft. We've got 0 for the medical and surgical section, 2 for the heart, 1 for bypass, 0 for one site on the coronary artery, 3 for an open approach, 1 for an autologous tissue device, and Z for no qualifier. It's like a giant puzzle. If the physician doesn't document the exact number of arteries or the specific approach, the coder simply cannot build this code. The real heart of this 7-character structure, though, is the 3rd character, the root operation. Precision here is absolutely crucial. The root operation defines the exact objective of the procedure. For example, we have to clearly contrast these two, excision versus resection. Coding an excision when the surgeon actually performed a resection fundamentally changes the code and potentially changes the entire DRG assignment. Because an excision is just cutting out a portion of a body part, like a biopsy. A resection is cutting out the entire body part. So if a surgeon just writes removal of gallbladder, clinical documentation improvement teams have to query that to ensure it's clearly coded as a resection. We see the exact same thing with respiratory support. It requires pinpoint accuracy. A CPAP machine provides assistance, whereas a mechanical ventilator delivers total performance. That single word difference directly impacts the mechanical ventilation time tracked for the DRG. If you put a patient on a mechanical ventilator for greater than 96 hours, that DRG shifts dramatically compared to simply assisting them with CPAP. Let's bring all of this together with a real-world, high-impact clinical scenario. Let's talk about sepsis. This is a scenario where clinical documentation improvement literally makes or breaks a hospital's revenue. Sepsis is one of the most heavily audited conditions out there. Providers have to explicitly document whether it was present on admission and if it escalated to severe sepsis with organ dysfunction. You absolutely cannot just assume sepsis because you see an infection and a high white blood cell count. And vague terms like bacteremia or urosepsis, they just don't cut it anymore. To capture that MCC, the provider must clearly document severe sepsis or septic shock and explicitly link it to the failing organs, like an acute kidney injury. This breakdown right here really hits the nail on the head and proves our ultimate point. Vague charting yields poor groupings and massive compliance risks. But complete codable documentation ensures appropriate reimbursement for the resources consumed. Think about it. If the discharge summary just says chest pain, you lose out entirely on the severity of the case. But if it specifies an acute anterior wall MI managed with PCI, well, now you've secured the right DRG tier and accurately reflected the intense resources your facility utilized. Precision isn't just for coders, folks. It is a clinical and operational mandate. Every single vague note or missing POA indicator is quite literally leaving earned resources on the table. So I want you to take a look at your own charts. How many revenue dollars is your facility losing today simply because a diagnosis lacked a POA indicator or a root operation wasn't specific enough? Think about that. And hey, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. See you next time.